that you are on mute, and we strongly recommend turning on your camera. We will begin shortly. Thank you. All right. Assalamualaikum warahmatullahi wabarakatuh. Greetings to our speakers, Ms. Inge Dhamanti. Good morning, Ms. Inge Dhamanti, and also good morning to our second speaker, to Professor Cyrus, engineer. Good morning, sir. And also good morning to all ladies and gentlemen in this room. Welcome to the World Patient Safety Day Research Week, Day 5, with the theme, oh, I'm so sorry, I forgot the theme. With the theme, patient safety in hospital. I am so sorry about that. I'm sorry, let me introduce myself. I am Nindya Arifani, and I will be the MC and the moderator for today's event, starting from 8 in the morning until approximately ends at 10 this morning. It seems like our speakers are already here. So without further ado, let's start today's event. Before we begin, I would like to introduce our speakers. So to the operators, please show us our first speaker, Ms. Inge Dhamanti, curriculum. Okay. Yeah, Ms. Inge Dhamanti, S.KM, M.Kes, M.PH, PhD from the Faculty of Public Health, Universitas Airlangga. Our speaker will bring the topic of Indonesian hospital readiness and the impact on patient safety during COVID-19 pandemic, based on health workers' perspective. She is an assistant professor at the Department of Health Policy and Administration, Faculty of Public Health, Universitas Airlangga, with several research interests, including safety and quality. Her latest publication was published in 2021 with the title Comparison of Patient Safety Incident Reporting Systems in Taiwan, Malaysia, and Indonesia. Her latest education was as Doctor of Philosophy from La Trobe University, Australia. She is also a lecturer and researcher, Faculty of Public Health, Universitas Airlangga, and the head of Center for Patient Safety Research. Yeah. So without further ado, I would like to welcome our first speaker, to Ms. Inge Dhamanti. The screen is yours, ma'am.
Good morning, Nindya. How are you, Nindya?
I'm great. Thank you so much. How are you, Miss?
I'm okay. Please give me a second. My son just wake up. Okay. Thank you so much for the introduction. Before I start, I would like to say hi to Professor Cyrus. Good morning, Prof. Cyrus.
Good morning, Inge, and good morning, Nindya. Pleasure to be here.
Yeah. Okay. Thank you so much for joining us. I know it's around 9 p.m. on Friday night in the United States. So yeah, thank you so much for giving some time to do this lecture. Okay, Nindya, thank you so much. So I'm gonna start my presentation today. So share screen. Okay. Okay, thank you. So, okay, so this is the first day or the last day of our research festival, and some of the members from the research group already presented their research. Some are already done, and some still ongoing. So this one is still the one that we conducted last year, and this is the theme. we also have Budiah Indriani here who do the data analysis, and also Dr. Miftahus Surur. So the title of the project is Indonesian Hospital Readiness and the Impact on Patient Safety During COVID-19 Pandemic. This is based on the health workers' perspective. Okay, so just a little bit background on the updates on COVID-19 in Indonesia, because I'm pretty sure that all of us already familiar with this one. And as of 15th of September, we already have like a more than 4 million confirmed COVID-19 cases, with more than 139,000 deaths. And we believe that this one is underreported. And also we have almost 4 million patients that have recovered from the disease. Additional data that we need to highlight is that more than 1,500 health workers died due to COVID, and this was the highest in Asia on July 2020. And also child death is also the highest in the world. So we need to look at this number very closely. And okay, and this is actually we could say that the government have done so many things to improve the condition and handle the pandemic. If you still remember that this is the first month when the government declared that there's a COVID pandemic. So the first thing that the Indonesian government do is evacuated Indonesian citizens from Wuhan. If I'm not mistaken, it's around 250 Indonesian citizens. And also the government has established National Task Force COVID-19, and also issued several laws and regulations to support the implementation of social restriction, and also to mitigate the disease transmission. And also Ministry of Health issued several circular or guidelines to have health services adjusted to COVID, and also appointed 835 referral COVID referral hospital, and also additional hospital that defined by the governor. And government also pushing the vaccination, and for this month we get this number. So more than 76 million Indonesians have received their first vaccination, and more than 43 million have received the second dose of vaccination. So this is the good news one. Okay. However, despite several efforts that have been conducted by the government, we could see that our health services are struggle. This is not only happen in Indonesia, but I think it's happen everywhere around the globe. So we could see that there's a crisis on the oxygen, on the hospital wards, isolation room, and also we could see that the government tried to adding the number of beds available for COVID-19 pandemic by turning the car parks into emergency room, or maybe just build the temporary hospital or field hospital or tent hospital. And you could see here that the condition of the hospital itself is like a very, very basic like this. And also, this is the article that I wrote in the conversation early months of the pandemic. We could see that that this condition can give consequence to the safety of the patient or the patient safety. As we can see in this picture that this happened in one hospital in Yogyakarta, that 63 patients died because of the oxygen shortage. Okay. So I borrowed two slides from my presentation on Wednesday, who talk about the hospital readiness and the role of a hospital. So we know that within health system, hospital play critical role in providing health services and crucial medical care. And this is really important during the time of crisis. And we also understand that when this pandemic happened, there will be many patients needing medical care at the same time. So there will be surge on the isolation wards, intensive care unit, and also human resources. So this is very important for each hospital to have the capacity to extend their services or adjust with the disaster condition. But this is really difficult. So even though the part of our accreditation, hospital accreditation system already cover the hospital disaster plan, but still it is very difficult to activate the system when the real disaster happen. So we could see also that there are so many changes on the infection prevention and control procedure. We see good improvement in hospital within we could see this within the first year of the pandemic. So I also found this information from the data that I collected for this research. However, we still have high number of infection in health worker. Also, the highest death on July. We also have to think about the disruption to essential care, which will have a long consequence for mother and child health, also for people that have the communicable or non-communicable disease. And providing high quality services, this will be another big issue that we need to handle. So if we talk about the quality of care in Indonesian hospital, even before the pandemic, so Indonesia have so many challenges that happen not only at the district level or hospital level, but also at the national level. So if you join the lecture on Tuesday with Professor Afzal Mahmud and Dr. Ardian, who talk about how the health system and quality of care become the most significant contributing factor to maternal death in many area in Indonesia, not only in East Java. So from this article, we could see that there's a poor application of protocol, poor information flow between health workers, also among institutions, delays in care, delays in management of deteriorating patient. Also, we could see that there's a difference in the quality of care that delivered among the urban area and also remote area. And also, if we talk about the medication error, uh, the incident related to medication error is always recorded the highest in healthcare in Indonesia. So from this article, you could see here that from the 7,000 drug dose that were reviewed, so like 20% of them representing an error. So this is a huge number. And also, if we look at this review and compare with other country in Southeast Asia, we could see that we have the problem. So it's the problem with the quality of care in Indonesia is actually already persist even before the pandemic. So if we look at the impact of the COVID-19 on the non-communicable disease and health system, we could see here, this is about the frontline healthcare worker burnout that was presented by Bu Shiva on, I think, on Thursday. Now, so we could see here the shortage of mechanical ventilator, delays and cancellation of elective procedure, and many, many more that give the consequence, whether it is direct or indirect, to the health system. So if we talk about the hospital in Indonesia, we have more than 2,900 hospitals, And each hospital have to be accredited. So within 2 years after they operated. So I could not recall whether we already have like more than 60% of the hospital that already accredited in Indonesia. Maybe the percentage maybe is a bit higher, maybe around 70 or 80. And we have like 6 category of accreditation. And this is from the not yet accredited because they just built or they just open, and then we have prime, basic, middle, and also the excellent. That's the highest category one. Okay, so the aim of this study actually, we want to know the impact of hospital readiness on patient safety. So we use the health worker perspective, and we use the mixed method in this study. Okay, so the research design is explanatory as sequential design, where we conducted the quantitative. Hang on, I'm sorry. Sorry, can I just pause for a second?
The audience member, don't forget to fill in the attendance form in the chat column. Yeah. To all participants and audience member, don't forget to fill in the attendance form in the chat column. Thank you.
Okay, sorry Nindya for the interruption. I already get the rescue to get my son who just wake up. So I'm really sorry for all the audience and also Prof. Cyrus. So let me continue. So the research design was explanatory sequential design, where we do the quantitative phase first that followed by the qualitative one. So we have like 235 participants from all over Indonesia. And also for the qualitative, we also have like 11 participants. So at first we have like 16 participants who were willing to be interviewed, but some of them just cancel in the last minute, and also didn't show up on the Zoom interview. Okay, so the hypothesis is we want to see whether hospital ownership and hospital accreditation affecting hospital readiness for COVID-19 and patient safety incident. So why this one is interesting? We thought this one is interesting, as we know that there's a different hospital ownership in Indonesia. Some of them are owned by government, provincial government, or maybe district government, and also some owned by religious organization, and also private. And also some were operated by university, like the one that we have in Airlangga, Universitas Airlangga, and also one owned by military. So we thought that this kind of ownership will affecting how the organization manage. Okay, and these are the variables that we want to look. So we look at the hospital status, the accreditation, and the ownership. And also we look also at the hospital readiness. So there are so many areas within hospital readiness, but we only look for 4 areas, which is human resources, incident management system, infection prevention and control, and also surge capacity. So we do the analysis using descriptive statistic and also confirmatory factor analysis. And also we use NVivo and thematic analysis for the interview. Okay, so this is some of the hospital details that we got from the respondent. So regarding the hospital ownership, like 66% of the respondent work in the government hospital, and the accreditation status, based on the accreditation status, like 69% work in the excellent or paripurna status, which is the highest category within the accreditation. But we need also to look at this one, the one that I highlighted blue. This one is the not yet accredited, which in here, the respondent are from the field hospital or the athlete hospital in Jakarta. And if you look at the size of the hospital, so most of the respondent coming from medium-sized hospital with most of them having more than 10 ICU, and most of them working in COVID-related unit, and also they serve more than 10, I think this is the highest one, more than 10 COVID patient every day. Okay, so within the quantitative result, we distribute like 45 question through Google Form, and because this study was conducted on October and November until December last year. So we categorized the participant answer, and we found that most of them have a good incident management system, good search capacity, good infection control and prevention, and also a good human resource arrangement. However, most of the participants think that in their hospital there is still some problem related with the patient safety incident, like 50% think that is in the average condition. So this is the PET analysis that was conducted by Budia. So we could see that from this graph, the ownership, accreditation status, and hospital readiness directly affecting patient safety incident. Okay, so how does the qualitative data support the quantitative finding? If we look at the qualitative participants, so we have 11 participants. Their profession was vary from resident, pharmacist, risk manager. Most of them are nurse, and 2 of them are medical doctors, and most of them working in the excellent or paripurna hospital, and 2 of them came from the not accredited hospital that owned by military. So this is our field hospital, or this is the athlete hospital. Okay, and the ownership status is vary as well. We have some 2 private hospital. Okay, so we do the coding, and we find that within the hospital readiness, we just look at the variable that we find here, and there are 4 area, and this is just this is some example of the code. So I just do it briefly here. So within the incident management system, the nurse from the private hospital with the status prime or terakreditasi utama say that the hospital already has an emergency response plan, and also the other respondents say that they already implementing pandemic disaster plan with the screening, triage and cohorting, and also zoning, and also this one is from private hospital. So this private hospital actually is like one of the network of the private hospital with more than 40 hospital in Indonesia. So I assume that they have good resources, and also they have a good networking. So when the news that COVID has started in Jakarta. So they quickly do carry risk assessment and also use the guideline from WHO to do assessment on the condition of the hospital. And about human resource management, we could see here the one from the temporary hospital. The participants say that to cover the need of human resources at that time, so the Ministry of Health recruited volunteers from all over Indonesia. So everyone is like gathered from around Indonesia to work in this hospital. So this from cleaning service, porter, decontamination team, and also all the health workers are recruited by Ministry of Health. And this one from a nurse from private hospital. So he highlighted that they did not carry out training, but only created the SOP and expecting that all the health workers read the SOP and implement the SOP. And also, this is from district government, first time accredited hospital. They say that they recruit staff from other hospital, public health center, and also student who's doing internship. And this one is from the private hospital. They I think they were very lucky because they could borrowing staff from other hospital in other province who was that time was the COVID cases not that high, and they're lucky because they have like a standardized skill. So even though they borrowing from other hospital, they didn't have to do like additional training because the skill already standardized by the hospital network. So about infection prevention and control, we could see that there is so many improvement within the first year of the pandemic. However, at the early months of the pandemic, we remember that there is a lack of PPE, masks, and hazmat. So the nurse from the district government, first time accredited hospital, say that they use raincoat and also they wear double or triple cloth masks because surgical masks at that time were very expensive and very rare. So this one is a nurse from the military or not accredited hospital. They say that he highlighted the material or of hazmat because at that time there's a lack of a hazmat. So the community start to like producing the homemade hazmat with the material that not following the not following the WHO or Ministry of Health standard. So they say that because it is a field hospital, so they depend on the standing AC, and also I didn't ask whether the hospital has the generator or not, but I say that when it was blackout, so they were sweating and some health workers were already saturated with the saturated rate that under the standard. So this actually really dangerous because they should be in the prime condition to give the care to the patient. Okay, for the surge capacity, so the nurse from the private hospital, they say that they could recruited health workers, so doctor, health analysts, and nurses. And also this one, once again, from the private hospital, they, when the number of cases increases, they open one floor and new building in front of area of the hospital. The emergency room was paraded around April. So it's like they do everything really smoothly on the early months of the pandemic. And this one, this participant told me that the condition of the hospital actually, because it was old building, so it is very hard to modify the building to give, for example, more fresh air circulation or change the zoning and everything is very difficult. But regarding the human resource need, yeah, she said that they need to good the she need to arrange it, what you call this is smart in arranging the health worker, because some of them get infected and they need to do isolation, and then but the lucky thing is they never close their emergency room. So even though there are so many health workers that get infected. Okay, so this is related with the patient safety incident. We could see there is some 7 coding. So I will be quickly on this one. So the most common incident based on the interview participant, actually the same with what the participants say in the questionnaire. So the most common incident is a mistake or delay in diagnosing the incident, which caused that the patient not receiving treatment according to COVID standard. Also delayed treatment, the service was not optimal, failure to communicate among health workers due to hierarchy and communication system that have to be adjusted to a system that constantly being changed. So yeah, we understand that at that time there is so many unclear situation, and this is uh, unfortunately affecting on the ability to communicate among health workers. So administrative error also reported, and this is from the not accredited hospital and misdiagnosed. And also the one participant said that she thought that the incident could be more, but maybe underreporting because most of the health worker were busy providing service to COVID patient. The administrative error, this is quite unique because this administrative error is reported morely on the non-accredited hospital. So it's like the problem with the room arrangement, because patient move to other room without tell the health workers, then this give consequence to the swab schedule and also to the treatment. And also some mistake in screening some document, which caused that actually the patient was negative, but because of the mistake, so he was sent into the isolation room. And also mix up on the label sticker, are also mixed up on the diet, also reported in other part. So the delay and referral, the referral hospital did not respond. The referral response was not too fast, maybe because too many patients are referred to the hospital. So that like unexpected things such as death occur in the hospital because uh, uh, patient waiting for too long. So delayed treatment also reported like limited screening room and isolation and difficulty of finding a referral hospital, and also stagnation in the emergency room. So this caused the, for example, the patient need a ventilator because the number of ventilator in each hospital was like limited. So they need to be treated in the emergency room. And also one nurse reported that about the patient is already in critical condition, unconscious, will have been intubated, but because there's no instruction maybe, or there's no because they could not do the intubation, so it will be the anesthetic, and also lack of ventilator. And this one is that happen often. So in many hospitals, the patient ward are using CCTV. So if, for example, if the patient was suddenly in trouble, at most they had to wait for about 15 minutes because the health worker have to wear the complete PPE before entering. So it's like a delay of 15 minutes to receive treatment in isolation ward. So, and also the service was a bit slow. The patient was not immediately escorted to the room, which ended up waiting for a while. It's also reported from the temporary hospital. And other is misdiagnosed. So at first is initially diagnosed with typhus, but then the condition did not improve, and then it turned out to be COVID. So after checking, it's like two health worker tested positive because of this, and mixed up on the patient name, patient diet, and also misdiagnosed due to non-specific COVID-19 symptoms. Okay, so what we can conclude from this study is actually, if you could see that hospital readiness has been affected by the status of hospital accreditation and hospital ownership. So in this research, and also no hospital in the world was ready for COVID-19, but a year later, so after the pandemic started, we see some changes in hospital readiness, but unfortunately not in patient safety. And we could see that from the survey and also from the interview, we could see that patient safety incidents have occurred regardless of hospital status, with delay in treatment being the most common incident, and administrative error also have been reported in non-accredited COVID-19 field hospital. So maybe for the future research, we could work on how to improve the quality of care in all type of hospital. Also, also about the operationalization of temporary field hospital, we need to how to maintain the quality of care in the temporary field hospital. So this is the end of my presentation. Thank you so much, Nindya. I'm sorry, I think it's a bit long. Thank you, Nindya.
Yeah, thank you to Ms. Inge Dhamanti. It's perfectly fine. Thank you too for the amazing presentation. And to the audience member, if you have any questions for Ms. Inge Dhamanti, you can submit the question now through chat, but the discussion would start after our second speaker. You can submit the questions in Bahasa Indonesia or in English. Yeah. So moving forward to our next speakers, the operators. Please show us our second speakers, Professor Cyrus Engineers Curriculum Vitae.
Good morning, everybody.
Good morning, Professor.
And a happy Patient Safety Week. It's a pleasure to be here. And should I share my screen? Is that okay?
If you don't know, Professor, I would like to introduce you first by reading your curriculum. Okay?
Sure. Please go ahead.
Thank you. Professor Cyrus Engineer is Professor Cyrus Engineer, Doctor of Public Health, is a clinical professor at Towson University in the College of Health Professions in the Department of Health Sciences, where he directs the Bachelor of Science program and teaches undergraduate and graduate courses in healthcare management. And also, Professor Engineer is a clinical professor at the Healthcare Management at the Department of Interprofessional Health Study, College of Health Profession, Towson University. He is also an adjunct professor from Johns Hopkins Bloomberg School of Public Health, Baltimore. So Professor Engineer's professional experience include being a project lead for the Save Lives, Clean Your Hands campaign for the World Health Organization. Professor Engineer planned and executed a global campaign on hand hygiene to reduce healthcare-associated infections. With many honors and awards, including an award in 2013, a Global Achievement Award for Johns Hopkins University alumni in 2013. His most recent publication in 2017, a journal article titled "Applying Decision Science to the Prioritizations of Healthcare Associated Infection Initiative." His interests lie in the areas of health systems performance, quality management, patient safety, and performance excellence. Now I would like to welcome our second speaker, Professor Cyrus. The screen is yours.
Thank you very much, Nindya. Thank you. Let me see if I'm able to be successful here. Are you able to see the slides? Okay. Good morning again, and it's a pleasure to be here. Thank you for the warm and generous introduction. It's a pleasure to be here again. So today I'm going to talk about, again, hospital preparedness, but more specifically a program from the WHO to improve safe surgery. I'm sure you've heard of a family member, a friend, a colleague, somebody who's gone through a procedure. Procedure could be something as simple as a minor procedure in a surgical room, a major procedure, and you've been under anesthesia. And so this is about, safe surgery. So this is a program that WHO had about surgery, about improving safe surgery. The idea that safe surgery saves lives, actually, and surgery is a public health problem, And I'll explain why it's a public health problem, because people might think surgery is as a tertiary intervention. You have public health, which is preventive and promotive, and you go to the hospital, that's more curative, and that's what you call a tertiary intervention, but safe surgery is also a public health problem. And here's why. The three problems in surgery are that it's not recognized as a public health issue, and we'll talk about that based on the numbers. When we talk about public health, we talk about numbers, volumes, and population, affecting populations. And let me ask you, all our colleagues here on the call today, what they think, how many surgeries are performed globally each year? Does anybody know? Okay, well, we'll continue. Maybe we'll ask later. So there's lack of data on surgery and outcomes. We don't know as much as we should know about how many procedures are performed and what are the outcomes of these surgeries. And then the last part, the third problem is that we don't know how to use the existing evidence on surgery. There's a lot of variation. There's a lot of variation on surgery. What is the prophylaxis, how these are conducted, and so on. So these are the three problems in surgical safety. And so just as I asked you this question, the answer is here. About 234 million surgeries are done globally each year. Some people say these are more than the number of annual births that are occurring each year. More surgeries are performed than the number of babies born each year. And you can see that right there in that chart right here. You have more surgeries and they are all on the rise. It is debilitating, surgery has also high rates of morbidity and mortality. At least 7 million people a year experience disabling surgical complications, and more than 1 million people die each year of surgery. So if I ask the audience here, have they heard of somebody who died after surgery, who died in the operating room. I'm sure somebody would have some information here to share. Some people get surgical infections after they have surgery. And so it's an unrecognized public health issue. The burden of surgical disease is increasing. In other words, because of technology, advances in treatment, and growth in incomes and access to quality care and surgical facilities, you've got more and more surgeries, and the burden of surgical disease is increasing globally. Yeah, so that's another. The second problem is we don't have good quality data on surgery and outcomes. We don't have national surgical registries that tell us how many surgeries are performed at all the hospitals in the country, in the state, or globally, or in the region. And when you don't have data, you're not able to make decisions about the trends and so on. There's lack of surveillance systems, unlike maternal mortality. In maternal health, we have made a lot of improvement in mother and child care because we have information and data and surveillance systems that help us determine, what the status is. So what the status is of maternal health and what the outcomes are. So unlike that, we don't have data, good quality data or surgical registries across, and that's a huge problem. The third problem is we don't have standardized care in terms of surgery. And because of that, there's a lot of variation in surgical care, depending on the facility, whether it's accredited, what kind of practices, the kind of training that physicians go through, what is the surgical site infections because of inconsistent timing of antibiotics before surgery. The anesthetic complications are anywhere between 100 to 1,000 times, and they are higher in some countries that don't have monitoring standards. And we all know that sometimes the wrong patient, the wrong site, the wrong patient is operated upon with the same name, wrong site instead of the right hand, the left hand, or the right leg, the left hand. And because of this, you have a lot of variation in the quality of surgical care. And so this campaign, Safe Surgery, Save Lives, was initiated by the WHO. And I was associated with this at that time with Dr. Atul Gawande. If you heard of this gentleman, he's written a book called, it's about the Safe List Checklist Manifesto. And he writes for the New York Times as well. And so he mentioned about promoting surgical safety as a public health issue, that it is important because of so many procedures that are performed globally. And what he did was with colleagues in nursing and medical colleagues, he created an evidence-based checklist, a checklist which is evidence-informed to improve standards of surgical safety. And the third goal of the third strategy was to create a registry for surgical vital statistics, almost like maternal health or death registries, to find out how many surgeries are performed each year by country. So this is what we have in terms of what we call surgical care. Currently, hospitals do most of the right things on most patients most of the time. Do you agree? Most of, but the checklist, if you have a checklist which you follow all the time, the checklist helps us do all the right things on all the patients all the time. Yeah, so it's like you're following a checklist right here. So I think that was what it is. So what's the checklist and where did this checklist come from? The checklist came from aviation industry. All of us take planes and fly to different places, right? We do that, right? We take an aircraft when we want to fly. How many of us worry that we are not going to make it when we step on board a plane? Do you feel frightened when you step on an aircraft that you might not survive? How many of you feel afraid, when you come onto a plane that you're not going to land? Again, this is just a question, but most of us don't, because we feel rather safe because they have the science of safety figured out and they use checklists. All pilots use different types of checklists to ultimately ensure safety. One of the checklists, different types of checklists that they use before the plane takes off, before it lands, whilst it's in the air. And so this is a principle that is borrowed from aviation industry and in healthcare, and something that we need to do. Not a check sheet, but a checklist of important aspects that people need to understand so that they don't make mistakes. And that is what we should borrow in healthcare. And so there are different types of checklists. One's a do list, where the pilot is asked to do step 1, step 2, step 3. And a second type of checklist, which is called a challenge, where the pilot is asked, did you do this? Did you do that? Did you? And so they use a challenge response checklist. And so in healthcare, we can benefit a lot from these checklists. And these checklists were introduced in healthcare and have benefited healthcare. And the surgical checklist is one example. What are the advantages of a checklist? One is it's customizable. You can have a general checklist, but you can customize it so that you follow SOPs, that everybody does the same thing, that nobody misses a step. It is also supported by evidence. So you don't include everything on the checklist. You include only those steps on the checklist that is supported by evidence. It's evaluated. So it's not just that you just create a checklist and use it, but it's used everywhere. You know, make sure that those steps are the right steps on the checklist. And then it is important for patient safety. So you want to standardize patient safety. You want to minimize variation. And also it doesn't cost much, unlike, having other safety interventions, a piece of paper that includes all the evidence-informed interventions. And that's what are the advantages of a checklist. And so WHO had, over a 2-year period, surgeons and nurses and anesthesiologists and patient safety experts from around the world to develop 10 objectives for safe surgery. So what are the 10 main objectives for safe surgery? And this was done using peer-reviewed evidence and expert consensus. So these are the 10 objectives for safe surgery. The first one is, you can read about each of these, but the first one was that the surgical team will operate on the correct patient at the correct site. You don't want to operate on the wrong patient, or on the wrong site. The second objective was to use, to prevent harm from administration of anesthesia while protecting the patient from pain, that you want to administer anesthesia so that the patient does not have pain, but some anesthetics can cause harm. So you want to prevent that. Then if something were to go wrong, then there is a process that the anesthetic team and others in the surgical room would be able to address, like airway, loss of airway or respiratory function, loss of blood, high risk of blood loss or allergic reactions. So there are things that they could do. And so these are the 10 objectives. The sixth one is you use methods that prevent risk of infections, mainly surgical site infections, that you don't leave foreign instruments, surgical instruments or sponges in the surgical wounds, that you will identify all the surgical specimens that need to be sent to the laboratory, that you will not miss that you will communicate and exchange information for safe conduct of operation, just like in an airline, in the cockpit. We are at this height, this is what we are going to do. And then there will be a public health system that will establish routine surveillance of surgical capacity, volume, and results. So these were the 10 objectives. And through these 10 objectives and through the consensus process and evidence, WHO created a surgical checklist. This is the checklist that addresses the 10 objectives. There are steps on this checklist. And if this checklist is put in operating rooms, every operating rooms, it can lead to safe surgery. That is the evidence right there. So the checklist is evidence informed. You have to check boxes. It has several questions. Before induction of anesthesia, what are the few steps that you need to take? Before the skin incision occurs, what are the steps that need to occur? And before the patient leaves the operating room, some steps that are evidence-based. So these, if you answer these questions, and so this is just to give you an example of what are the questions that are before induction of anesthesia. So what are the things you want to do before induction of anesthesia? You want to make sure that you have the right patient, yeah, you have the right site, that you have a pulse oximeter so you can monitor, the oxygen and other aspects, yeah, and you want to know about the allergies. Is this patient at a risk of airway or aspiration risk? And is there a risk of bleeding? So this is what you do with at least a nurse or an anesthetist. This is before the induction of anesthesia. You want to make sure that the patient has confirmed the identity. Yes, my name is so-and-so. The site, the site is marked, what procedure, and there is an informed consent. So this is the first before. This is before skin incision. So you confirm that all the team members have introduced themselves. Yeah, you want to make sure that the doctor introduces, the surgeon introduces the team and the patient and the procedure and what is going to occur, what's the patient's name and the procedure, where the incision will be made, and the antibiotic has been given within the last 60 minutes. And then what are the anticipated critical events from the surgeon's perspective, for the nursing, and do we have the images, the radiology films, etc., all available and displayed. So this is before the skin incision. Then this is before the patient leaves the operating room. The nurse confirms the name of the procedure, the completion of the instrument, sponge and needle counts, the specimen labeling, if it has to be sent to the lab, whether there are any equipment problems to be addressed, and to the surgeon and anesthetist, what are the key concerns for recovery and management of this patient before the patient leaves the operating room. So these are what you call, this checklist was tested. So you don't want a checklist that is not evidence informed. So this checklist was tested at 8 sites all over the world in different regions of WHO, at different hospitals it was piloted. And it was found to reduce the rate of post-operative complications and death, surgical complications and death by 33%, almost 33%. This study was published in the New England Journal of Medicine. And, just implementing a simple checklist and this before, during, and after reduce the surgical complications and surgical mortality by over 33% or over 1/3%. This is some data from that paper that you see, what was it at baseline after the checklist was implemented, and you can see the reduction in death and complications. But you can also see that not just death and complications, but it also had statistically significant improvements in surgical site infections and unplanned return to the operating room. Unplanned return to the operating room, which is you have a patient go out and then the patient comes back because of some complications. You need to go back to so this is an aspect of surgical safety, and all of these were statistically significant. Because there were 8 sites, this study also looked at low-income and high-income countries, and the findings were similar, that the checklist was effective. The checklist was effective in both high-income and low-income countries to reduce the mortality rates. So this was what you call also another study that was published. And this is an evidence-informed checklist. So every step on the checklist, is based out of evidence. So it's not just because the doctor feels or so on. So the evidence is presented on the right, and that the steps that are included on the checklist are on the left. And so the evidence supports the steps on the checklist, because you don't want a checklist with about 50 steps, which makes it very difficult. People don't like to fill up the checklist, but this is all based on evidence. So here's the evidence. So this is the evidence for before induction of anesthesia that supports the inclusion of steps. This is the evidence for, this is continuing. This is the evidence for before the skin incision. So there are studies that support each of those steps right there. Similarly, teamwork and the reason before skin incision to introduce themselves. There is a lot of evidence that if the teams introduce themselves, who they are, what they do, what the procedure is, it can lead to better surgical care. So teamwork is associated with better quality surgical outcomes. And so that's why these steps have been included. And then this is basically the last aspect of having a surgical registry by every nation, because the number of these are some examples of surgical vital statistics that every nation needs to collect. So number of surgeries performed in the operating theater per 100,000 population per year, number of operating theaters per 100,000 population, number of surgeons per 100,000 populations, number of anesthesia professionals, day of surgery mortality rate, post-operative in-hospital mortality rate. These are some of the indicators that if we collect and if we share, we can do better on surgical outcomes. So that is what it is. And it's easy math. About 500,000 lives are on the line each year. 500,000 people, 500,000 lives are on the line each year. And at least half are avoidable by the utilization of this checklist. So WHO has created this checklist, and we encourage you to use this checklist. There's a lot of information on how to implement this checklist. There's an implementation manual, there are guidelines, and there's a starter kit. If you want more resources, these are freely available for you to download from the WHO website. Safe surgery is indeed a public health issue. Lots of surgeries performed in every hospital, and so they can't be ignored. And with that, I'd like to say thank you and open up for any questions. Thank you.
Thank you so much, Professor Cyrus, for the amazing presentation. Now, and it seems like earlier we made a small mistake during the introduction. Professor Cyrus Engineer is now currently affiliated with the Johns Hopkins Bloomberg School of Public Health. Yeah. So now moving forward to the Q&A session, if the audience member have any questions to either speaker, whether to Ms. Inge Dhamanti or to Professor Cyrus Engineer, you can submit the question in the chat volume or by raising your hand. Seems like we already have some questions. So Ms. Inge Dhamanti, are you in the room? Is Ms. Inge in the room? Okay. There's one question to Professor Cyrus. Bagaimana mengantisipasi penularan COVID-19 di rumah sakit? Oh, I think I have to translate it for you, Prof.
Thank you.
Bagaimana mengantisipasi penularan COVID-19 di rumah sakit saat melakukan pembedahan, dan apakah ada checklist terkait pembedahan di masa pandemi? So the question is about COVID-19, how to anticipate the spread of COVID-19 in hospitals, especially during surgery, and is there any special or different checklist for surgery during this pandemic? That's the question.
Yeah, I think that's a question that a very important question, and I think Inge might have some answers to it as well. I think the general routine prevention IPC procedures are actually what people need to follow in hospitals, whether it is during a pandemic period or not. And so, the surveillance systems should be there in place. And, obviously you need more precautions and testing and, in hospitals, particularly for elective surgeries, you have patients and staff that are either tested and what you call vaccinated before surgeries are performed, particularly in hospitals, and then routine surveillance systems to inform the infection rates, etc. So that is what I'd say. But why don't I ask my colleague Inge to also jump in, because I think she has done this survey, and I'm sure she's heard either from the qualitative or the quantitative, what you call, results on, some surgical, what you call, procedures.
Okay, thank you, Prof. Cyrus. So, unfortunately, from all of my participants, they didn't highlight the issue regarding the surgery, because we understand that at that time, elective surgery was postponed and canceled. So only very limited surgery that could be held in the hospital. And based on the news, we heard that so many infection happen at the surgery unit because of the patient didn't tell the truth and something like that. And to my knowledge, there's no specific checklist for the pandemic, but we just use the same checklist for all the condition. Just like that, maybe. Thank you.
Yeah, now it seems like there are 4 questions for Ms. Inge Dhamanti, maybe to the audience. To Al-Habshi Kusumadinata, maybe you want to unmute yourself to turn on your microphone and ask questions to Ms. Inge directly, or maybe you want me to read the questions out loud to Al-Habshi Kusumadinata. Okay, so maybe I will read the questions out loud to Ms. Inge Dhamanti. Izin bertanya, yang saya ketahui di tahun lalu lonjakan kasus COVID-19 yang begitu tinggi membuat sejumlah rumah sakit kekurangan tempat isolasi hingga menyebabkan beberapa pasien terinfeksi COVID-19 beberapa pasien yang terinfeksi COVID-19 tidak dapat mendapatkan pelayanan dari rumah sakit, ditambah lagi jumlah tenaga kesehatan yang juga terbatas. Pertanyaan saya, bagaimanakah peran rumah sakit dalam menghadapi permasalahan tersebut di masa yang akan datang jika pandemi seperti ini terjadi kembali? Mengingat saat itu pelayanan kesehatan tidak sebaik sekarang dalam memberikan pelayanan kepada pasien terinfeksi COVID-19. Sehingga waktu itu orang yang positif COVID-19 bebas berkeliaran di tempat-tempat umum dan mampu menularkan pada orang lain. Terima kasih.
That's a very long one, Inge. Who is the
mungkin adalah bagaimana peran rumah sakit agar bisa mengantisipasi jika terjadi pandemi kembali seperti itu.
Okay, thank you. Okay, maybe Prof. Cyrus could help in answering this question as well. So the who's asking this question? What's the name?
Al-Habshi Kusumadinata.
Okay.
Professor Cyrus Engineer, the question is, how do we prevent from, what should we do as a hospital to prevent another pandemic from happening or to prepare for another pandemic to happen? That's the question.
Okay. So some point from the question is, Habsi asking about at that time during the July peak of the COVID-19, there's so many patients die and many patients that didn't get a treatment at the hospital. And the question is, what is the role of hospital so they could improve the service the next time if another peak happens? So in my perspective, actually, it's still using the WHO guidelines. The hospital could start improving in the area because they could use the hospital readiness checklist that issued by WHO. There are some area where they could assess their ability, hospital ability, and they could improve it from there. So I think that's very important as well. But in Indonesia, so in response to the guideline, Prof. Cyrus, so our Ministry of Health is actually issuing some guideline as well. So for all hospitals to be ready to do the self-assessment, then they need to do the assessment periodically. But until now, we haven't heard the follow-up from the guideline. So yeah, that's the current condition in Indonesia. So hopefully that answered the question. India, thank you.
Seems like we have a lot of questions from the audience. There's another question from Alvin Ubaid Hoiri to Professor Cyrus. The question is, or maybe Alvin Ubaid Hoiri, maybe you would like to turn on your microphone and ask to Professor Cyrus directly about your question to Alvin Ubaid Hoiri. Okay, it seems like I have to read the questions out loud. The question is, what if the patient is in emergency condition and is unconscious while they need emergency surgery? Can the checklist still be carried out because some information is still unknown, such as patient personal information or allergies that they have?
Yeah, very good question. And the idea is here, very good question. And so in an emergency condition, sometimes you have to make quick decisions and judgment calls, and you may not be able to ascertain the allergies or get all the information. So you got to do what you think is right and what's best, because you have to weigh the risks and benefits of delay and time versus what is important to do. So, I mean, yes, it's possible that during an emergency, you may not be able to follow all the steps in the checklist, but to the extent possible, you should try to do that as much as possible. So yeah, you're absolutely right in that. Yeah. So
thank you for the answer. There's another question from Ahmad Amin Mahmudin. Do you want to read the questions out loud, or do you want to read questions for you?
I think Dr. Amin is one of the alumni from our master student, and his research is related with the surgical safety checklist. So maybe we could invite him to ask directly to Prof. Cyrus.
that'll be great.
Dr. Aam, are you here?
Dr. Ahmad Amin, perhaps you are in the room and you can turn on your microphone. Is Dr. Ahmad Amin in the room? Okay, maybe I will read the questions first. Maybe Dr. Ahmad Amin can join the discussion. The question is this question is for Ms. Inge. On the aspect of hospital care, in my humble opinion, patient safety and COVID-19 treatment is still not a big issue to discuss specifically, because perhaps the focus of the hospital is the safety of medical health workers first. Availability of health workers and the transmission risk is often the reason for the continuity of service of the patients. Is this thought completely true after the pandemic is almost 2 years running worldwide? How do we respond to such thoughts? Inge Dhamanti, perhaps you're ready to answer?
Okay, thank you. That's a long question as well. So I try to find the question from the chat room. Okay, so patient safety is still not a big issue because hospital more focused on the safety of medical health worker first, ability of health worker, PPE. Yeah, I do agree with this one. So in Indonesia, especially, we're still focusing on how we could provide how all the resources could provide the safe care for the patient. But unfortunately, Dr. Amin is right that the patient issue is not highlighted in everywhere, or also in the media, or also in some paper. If we do just doing Google in Google Scholar or in other database, we could not find the patient safety and pandemic in Indonesia. So it's still a big area to study. So yeah, I think that is true. That is true. I don't know how's the condition in the United States, Prof. Cyrus.
Condition of, can you repeat that
in Indonesia, patient safety related to the COVID treatment is not a big issue because our hospital more focused on the safety of health worker and PPE and transmission risk and something like that. So how's the condition in United States, whether the patient safety program is running together with the COVID treatment or something like that?
Infections is a part of patient safety. And so I think it's part of the patient safety program. And so the patient safety officers are clearly engaged with the COVID-19 response more so. And they are involved in everything from what you call, testing, contact tracing, what you call isolation, vaccination policies, etc., all at the hospital. So it's integrated. It's part of the patient safety program.
Okay.
But there is something called occupational safety, which is for the healthcare workers, and so the occupational safety unit is also working closely with the patient safety unit in the United States, mostly in hospitals. The occupational safety looks at the health and welfare of the employees and the health workers.
Okay.
All right. So there's another question for Professor Cyrus Engineer, but from Abdurrahman Al-Maki. Does the checklist have an influence on employee or team satisfaction, or does it add to the employee or team burden?
Very good question again. There's a lot of paperwork, and one more piece of paper that we have to fill up and use and that also in the operating room just before an important event. And this is a very good question. And so there's some studies that have demonstrated, and you can look up in literature, that this actually enables frank, open communication, helps build confidence in the surgical team. And if done correctly, again, it's not like one person is filling up these as a checkbox and just completing it because the hospital requires it and putting it on the side. But if it is followed appropriately, then it actually improves teamwork and morale and confidence in the surgical team. It actually builds confidence because, the surgeon talks about the patient, talks about the procedure, what we are going to do, and then talks about all the steps. And so it does not add burden if it's done correctly. But if it is done just like a routine, like somebody else filling it up, then obviously it is not followed, that people don't believe in it. And then there is what he refers to as disobedience on the checklist. So it's like, I can tell you something, that before you take off in an aircraft, the pilot uses the checklist, the 5 steps or 7 steps on the checklist. And if he does not use this, he does a good job and he knows what the checklist is, make sure that the checklist is used, all the steps are followed, and it helps everybody. And so that's the whole idea. You need to believe in the checklist and you need to follow it because it is evidence informed. But if you use, there are a lot of papers that the hospital administration circulates, which has so many steps, too many steps, and then you just want to check, then it's not what you call going to be effective. Yeah.
Thank you so much for the answer, Professor. And now there's another question by Alisa Ika Hana. Oh, maybe Miss Inge wants to say something.
I want to ask question to Prof. Cyrus. Prof. Cyrus, while you're here, I want to know why there are some hospitals that choose not to use the checklist, because we know how to improve patient safety, but in here, also in Indonesia, we know that some hospitals don't want to use the checklist.
Yeah, you know what? It's interesting. Do we have surgeons on this call? Do we have many surgeons on this call?
We have Dr. Ardian in here.
Yes.
Yeah, Dr. Ardian.
Yes, so we should invite a surgeon to talk about, this. My experience has been that surgeons are in a rush and surgeons want to get things done. Okay. And surgeons want to get to the next case, and surgeons want to get in and out as soon as possible so that they can continue with their part of the day. Again, with good reason. Their focus is on the patient getting the procedure done and, moving the procedure out. And many times, they have support and the scrub nurse and others help them. But I think it's partly a bit of culture in terms of wanting to, there's so much paperwork, there's so much to do, there's lack of time, and there's a lot to do. And some of these things get into the way. The second is people believe that it's another piece of paper. And what is that piece of paper going to do? How is it going to affect? It's the skill, the dominance of skill and, my technique as the basis, and that I have it all under control. Surgeons usually are in control. They want to make sure that, they are in charge. So they know what people are doing, and so they believe everything is under control, and they don't really have to go through all the steps. It adds time, it's inconvenient, it's cumbersome. But I'll stop here to see what Dr. Ardian has to say.
Thank you, Prof. Cyrus. Absolutely right. You are absolutely right. Yes.
I didn't want to offend the surgical community here. Besides, that's why I asked, do we have any surgeons here?
Yeah. But I mean, yes, personally, yes, for me as a OBGYN who are very frequently to do the emergency C-section, yeah. Sometimes we need to be rushed, but actually it can be changed by the culture or by leadership, especially for nurses. So I hope here we have some nurses listening and watching this session, and please don't hesitate to tell the surgeon and stop the surgeon if the surgeon doesn't obey the rules. Yeah.
That's
think,
coming from your surgeon,
yeah.
Coming from your surgeon nurses. Yeah,
yeah. But if the nurses is quite have a strong leadership, and they said, no, doctor, you cannot start the operation until checklist is filled up. So the surgeon will obey the rules. I think that's my opinion, because I have experienced that the manager of nurses was very strict, and finally the surgeon is obey the rules. Yes, that's my opinion, Professor.
Thank you, Dr. Ardian.
Dr. Ardian, maybe you could help us in answering the question related the surgery checklist during the pandemic. Yeah, because I see that you have some you gave some comment in the chat room.
Yes, thank you, Bu Inge. The surgery checklist still be done in our hospital, especially in the UNAR hospital, especially for emergency cases. We should checklist the surgery checklist, but the problem is about the screening, Bu Inge. I know that the screening for the emergency surgery is quite challenging, but the screening should be done, but in a certain or specific way, rather in a very complicated, like on elective surgery we use PCR for the screening, but on a emergency surgery we use antigen only. But before operation, the surgery checklist should be performed. That's my experience, Bu Inge.
Okay, thank you. So the difference is only in the screening process.
Yes, the screening process. Yeah.
Okay, thank you so much.
Thank you.
Thank you.
Thank you, Professor Cyrus.
Thank you.
Thank you, Bu Inge.
Talking about surgeon and surgery, there's another question from Dr. Ahmad Amin. To Professor Cyrus. Each surgical team has the same responsibilities. However, the surgeon must play a major role. But in some studies, surgeons are considered to have a high hierarchy, so that if some errors or checklists are missed, nurses or other health workers are difficult to correct them. What do you think?
Yes, so I often use the example of Toyota Motor Corporation. There's a paper that they published which is called Pulling the Cord. You know, when Toyota, the motor company, manufactures cars, you know, it's an assembly line. There are different steps and the car's assembled. Ultimately, at the end, the car's ready to roll out of the assembly line. And so every assembly station, there's a number. And the way Toyota did what we call TQM, or total quality management, is they empowered any employee on the entire assembly line to pull a cord. When they pull the cord, the entire assembly line stops. No car, there's no, until that problem is fixed before it goes to the next stage. So I think there is a hierarchy in medicine that has limited the ability for safety and quality to make exponential gains. And I think that we need to be open to teamwork and communication and the ability and empower colleagues to speak up. You know, there are speak up campaigns that allow healthcare workers to speak up without being punished or without being penalized. And I think we want to minimize that hierarchy to the extent possible, like Dr. Ardian mentioned right now, that if nurses should be encouraged to speak up if there is a step that is not being followed. And it takes time. It's not going to happen overnight, but the culture needs to shift from what you call a very strong hierarchical culture to a culture of openness, of transparency, and of accountability, holding each other accountable. So it takes time.
All right, thank you so much for the answer. Professor, there's another question for you from Alisa Hana. Maybe Alisa Hana would like to turn on your microphone, so we would have a little interaction between the audience.
Okay, first of all, thank you for Professor Cyrus and Bu Inge for such a good knowledge that you share for us. I have a question for Professor Cyrus. First, my mother has a medical condition, which her neurosurgery doctor said that every surgery must be done with anesthesia for neurosurgery. If my mother has to undergo any surgery in another hospital that doesn't have her medical record, what should I prepare as her guardian to help the medical team so that they could perform the surgery safe and well? Thank you.
Thank you. Is that Benitia? Is that Alisa? Is that? I just want to make sure I pronounce your name all right. Well,
Yes.
Yeah, medical records form a very important basis for decision making for the surgical team. And as I don't know whether there are electronic health records that are exchanged or available, but if not, if before surgery, I think there are a couple of components that are essential. One is to make sure that you have all the medical records that, whether they are paper-based or they are electronic, accessible, so that the surgical team and the medical team is able to make informed decisions. The other important aspect is what we call, and I saw during the introduction, is an informed consent. Yeah, you want to make sure that the patient is neurosurgery or any other surgery, but especially neurosurgery, has risks associated with what you call the procedure. And so the patient is well aware of what the procedure is and what are the potential risks. So there is a proper consent. And, when you talk about informed consent, what are the, people often ask you to sign a piece of paper and then, you're done with it, but that's not the right way to do it. An informed consent is competent, willful, informed, it is intelligent, it is specific, and it's expressed. In other words, you want to make sure that the patient understands the benefits, the risks, what is likely to happen, and has the ability to have a conversation with the medical team, with the doctor, about all the benefits and all the risks of the procedure. Yeah, so I think you need to prepare. All the lab reports need to be there, all the films need to be there that are there, all the medications, all the visit history reports should be there. But this is all part of the medical chart. And typically all doctors and neurosurgeon will ask for all this information before making a decision on any part. So you don't need to worry too much, because they will want all this information. They will want all the labs as well. But good luck.
Yeah, thank you so much, Professor, for the answer. There's another question for you from Anissa Clara Salsabila. Anissa Clara Salsabila in Peru. Perhaps you would like to turn on your microphone and ask your question to Professor Cyrus. It seems like Anissa Clara here. That, so I would like to read the question for you, Professor. The question is, I have heard that there are side effects from every medical procedures. From that case, what can public health advocate do to prioritize patient safety and to minimize the adverse effects that may arise during a medical procedure?
Okay, sorry, Nindya, I heard part of that. Could you repeat the question one more time, please?
So the question is, what can public health advocate do to prioritize patient safety?
We can spend the next 20 minutes here, but there's a lot that public health advocates can do to talk about patient safety. I think one is what we call the bill of, it's a right for patients to feel safe, yeah, and public health advocates need to be having campaigns. They can talk about patient safety. They can talk about honesty and full disclosure. Some medical errors need to be talked about. Doctors and nurses and medical teams can talk about mistakes that they made. So they need to have these frank conversations. So, we all make mistakes. And the idea is that it is important to talk about these mistakes, because if we talk about these mistakes, we can learn from these mistakes. If we don't talk about these mistakes, they continue to occur. So to the extent possible, if the public health advocates are not adversarial, in other words, wanting to sue or to point fingers, but think about it as a partnership, because we all make mistakes. The important thing is to have a conversation and talk about these mistakes and learn from these mistakes and make sure that these mistakes do not occur again. So public health advocates need to be partners with the medical community to make sure that we make gains in patient safety and not criticize or point fingers at each other.
All right, thank you so much, Professor, for the answer. Oh, there's another question.
Sorry. Thank you for the explanation. Sorry, I cannot open my mic.
Oh, yeah, it's perfectly fine. There's another question for Professor Cyrus from Dr. Ahmad Amin again, perhaps, I think. Yeah. So the question is quite long. Let me read it out to you. So checklist is very well implemented in aviation so that the fatality or error rate is low. However, when it is implemented in hospitals, compliance is not well, even in poor countries. Adherence is not high. Is this different because flights are overseen by business-focused management, Or is there too many handover services in the hospital so that the healthcare worker is only used surgical safety checklist as just checklist exercise?
Yeah, so it's an important question. So I'm sure you might have heard of a term called Six Sigma or Six Sigma compliance. Yeah. Sigma is a measure of standard deviation, and an industry that is Six Sigma compliant has less than 3.4 defects per million opportunities. So you have less than 3.4 defects or errors per million opportunities. Yeah. And so aviation is considered to be Six Sigma compliant. In other words, that's why you don't think twice before stepping onto an airplane. You know, you will, once you are on board of an airplane, you are safe, you will reach your destination because it's Six Sigma compliant, less than 3.4 defects per million opportunities. And the way they have achieved this is through standardization of processes and standardization of systems. So what if I told you that every time you go into an aircraft, you know, the team in the cockpit is not the same. There's a different pilot, there are different what you call air hostesses, and they all come together, but it never feels that they are different. It's because of standardization of care, the standardization of processes that are there. And there is what you call these checklists that have actually helped. It's not just in aviation, but also in nuclear industry, you know, and space administration. And I think we in healthcare have a lot to learn about standardization of care and utilizing checklists to standardize care. And what has happened in healthcare is there are so many checklists that don't make sense, that are not evidence-based, that over time, there's so much paperwork that nurses and doctors feel this is a waste of their time, that it's not going anywhere, and therefore they feel that they should not adopt these checklists. So if administration and the technical teams, the medical officers spend some time, review all the papers that are floating around, review all the checklists, and come up with what you call a simple set of checklists that are evidence informed, like the surgical checklists that are known to improve safety, and they talk and communicate, and then then I think healthcare workers will improve the adherence or adoption of the checklist. Right now, there's just so much that is going on. There's so much paperwork. Nurses are spending more time doing paperwork than looking at patients. And there is this concern that there's less touch time to patients and more time spent on papers and documentation. And I think that takes away the spirit of what the purpose of a checklist is. So in aviation, there are not many checklists, but there are a few critical checklists, and these checklists are taken seriously. And if the pilot does not follow the checklist, guess what? They could lose their job. Does that happen in healthcare? Not quite.
Thank you so much, Professor Sales Engineer, for the answer. It seems like we only have the time for one more question, so I would read out a question from Shafira.
Yeah. I think there's one important question from Bapak Muhammad Abdurrahman Al-Maki. So I don't know whether, I think we haven't discussed this. So does the checklist have an influence on employee or team satisfaction? Or does it add like additional burden for the workers? So I think that's important.
Yeah, I think I answered that a bit earlier. Okay. I did answer it. I think if it is used wisely and correctly, it improves team morale, confidence, it opens channels of communication. But if it is left to somebody else, one person to fill it up just like a piece of paper, then it's more just a burden. Also, the data from the checklist and outcomes need to be analyzed. If you analyze these outcomes and the checklist, you capture the data, of the checklist, and then you look at the outcomes, the surgical outcomes. Did the patient have surgical site infections? Did they have any other adverse events? That is helpful to determine how useful the checklist is. Yes.
Adding to that, Prof. Cyrus, if we compare with the hospital readiness checklist, it has like a 12 area, and each area have like many questions. So it's more like the accreditation instrument. So yeah, this. So if we could say that this put additional burden to hospital. So yeah, I think it is related with the mindset maybe, or maybe the culture, or what's your comment about that one?
So as an administrator, I've been an administrator in hospitals and a CEO of hospitals. So I've seen a lot of checklists that are floating around, duplicate checklists with a lot of information that is not needed. And it does add a lot of burden. And I think there's a difference between a checklist and a check sheet. Yeah. And people don't understand the difference between a checklist and a check sheet. A check sheet is where you just check what you're doing for the patient. And a checklist is more meant based on evidence to follow a particular protocol. So if you have an SOP, a standard operating procedure that you convert into a checklist, you don't want to include all the steps. You want to include only those 4 or 5 critical steps on the checklist that are important, that are evidence informed. A check sheet can have 50, 60. And because there are too many check sheets, people think check sheets and checklists are the same. And therefore they think about a checklist as a check sheet. And then, there's not much attention paid to those checklists, if that makes sense.
All right. Thank you so much, Professor Cyrus Engineer, for answering our questions, and to Ms. Inge Dhamanti too for answering our questions. It seems like we are running out of time. So now the event has finally come to an end. And this also marks the end of the World Patient Safety Day Research Week. And once again, we would like to thank our amazing speakers. Thank you so much for coming here, for being here. And we would also like to thank our participants and audience for staying with us throughout this research week. This webinar, the recorded version of this webinar, will be posted on our YouTube channel at Pusat Riset Keselamatan Pasien. So be sure to check our YouTube channel after this. On behalf of the organizer, I would like to apologize for any mistakes done throughout the week. So that's it from us. Wabillahi taufiq wal hidayah. Wassalamualaikum warahmatullahi wabarakatuh.